Hello, everyone, and welcome to our module on antipsychotics. Let's start by talking about dopamine, which, as you probably know, is a neurotransmitter used in the central nervous system. In the 1950s, the drug chlorpromazine was found to improve psychosis, and then later it was also found to block dopamine receptors in the central nervous system. So this led to what's known as the dopamine hypothesis, which states that by blocking dopamine activity in the central nervous system, you can improve psychosis. And this is how many antipsychotics work. Chlorpromazine is just one of a number of drugs that came out many years ago and are called the first generation or typical antipsychotic drugs. All of these have some level of dopamine blockade in the central nervous system, and that's how they work. Haloperidol, which is also called Haldol, is still commonly used today, and these other drugs here are first generation or typical antipsychotics. Most of them end in azine. Most of these are not used that commonly today because, as we'll talk about later in this video, the second generation antipsychotics have less side effects. But nevertheless, these are the first generation or typical antipsychotics on this slide. The primary antipsychotic effect of the first generation antipsychotics comes through blockade of the D2 subtype of dopamine receptors. These are found on postsynaptic neurons in the central nervous system. You can find them in the limbic system, the basal ganglia, and the prefrontal cortex. They are coupled to G proteins, and there are two subtypes of dopamine receptors, the D1 and the D2 type. The D1 subtype activates adenyl cyclase and raises the intracellular level of cyclic AMP. The D2 subtype does the opposite. So if you look at the bottom of the screen, what adenyl cyclase does is it converts ATP into cyclic AMP, which looks a lot like ATP, except it's got a ring here attached to the nucleotide. So this is the normal role of adenyl cyclase, and it's normally inhibited by D2 receptors. So if you remove that inhibition, what will happen is the level of cyclic AMP inside of neurons will rise, and that's the effect of D2 blockade by first-generation antipsychotics. These drugs are sometimes called neuroleptics, which means a drug that depresses nervous system activity. They can be used in schizophrenia, although they're not used that often in the modern era. They're best at treating the positive symptoms, not the negative symptoms of schizophrenia. They're also used in other forms of psychosis, in mania and bipolar disorder, in OCD, in delirium, especially haloperidol is commonly used in the hospital to treat patients with acute delirium. And then finally, they can be used in Tourette syndrome and Huntington's disease. So the mechanism of action of first-generation antipsychotics is fairly straightforward to understand. It involves blockade of the D2 subtype of dopamine receptors in the central nervous system. What's more complicated about the first-generation drugs are all the side effects. They have lots and lots of side effects, and this is what's usually tested on your exams. And this is what we're going to go through in the next few slides. In the neurology section in our video on Parkinson's disease, I talk about how Parkinson's is a disorder of motor dysfunction where patients develop tremors and muscle rigidity. And in that video, I talk about how Parkinson's disease is associated with decreased dopamine activity in the central nervous system. And if you can remember this, then it's very easy to understand that once you start blocking dopamine receptors in the central nervous system with first-generation drugs, you are going to get lots of muscle symptoms, many of which resemble Parkinson's disease. Another thing to know about dopamine is that there are many other neurotransmitters that are also small molecules like dopamine, and they are also impacted by many of the first-generation antipsychotics. So for example, serotonin, which is also called 5-hydroxytryptamine or 5-HT, has a very similar structure to dopamine. So does histamine, so does epinephrine. Acetylcholine has a different structure, but it's still a small molecule active in the central nervous system, and some of these drugs also block acetylcholine, which means they block muscarinic receptors. So if you want to understand the side effects of all the first generation antipsychotics, you just have to understand that all these neurotransmitters are small molecules similar to dopamine, and they will often be impacted as well as dopamine in patients who take first generation drugs. So the goal of the first generation drugs is to block dopamine, but many of these drugs also block the effects of serotonin, histamine, acetylcholine on muscarinic receptors, and epinephrine and norepinephrine on alpha-1 receptors. And the different drugs have different degrees of blockade of all the receptor subtypes. So for example, chlorpromazine blocks alpha-1 and serotonin receptors equally and to a greater degree than dopamine. Haloperidol, on the other hand, is famous for the most dopamine blockade. It also has some blocking effect on alpha-1 serotonin and histamine as well, but not as much as dopamine. So the intended effect of the first generation drugs is to block dopamine receptors and improve psychosis. But to understand the side effects that patients get, you need to understand the consequences of dopamine blockade as well as blockade of those other neurotransmitters we just talked about. So when you block dopamine receptors, although you may improve psychosis, you can cause a lot of side effects, and most of them are Parkinsonian or movement side effects. These are called extrapyramidal side effects, and we'll talk about these in detail in a minute. In addition, when you block dopamine, you take away the inhibitory effect of dopamine on the pituitary gland, and that can lead to elevated release of prolactin. So hyperprolactinemia can occur. And hyperprolactinemia in women can cause amenorrhea. It can also cause galactorrhea and gynecomastia. And then finally, blocking dopamine, it turns out, is actually effective for suppressing nausea and vomiting. So some of the antipsychotics of the first generation function as antiemetics. In particular, prochlorperazine and chlorpromazine are both sometimes used even today as anti-nausea drugs. When you block acetylcholine muscarinic receptors, you get problems like dry mouth and constipation, and these happen with some first generation antipsychotics. If you block alpha 1 receptors, this can lead to hypotension, and if you block histamine receptors, this can lead to sedation and constipation. So all of these are side effects you can see in patients taking these first generation drugs, and it depends on which drug is used and to which degree it blocks each receptor subtype. I told you before that blockade of dopamine receptors can lead to movement side effects that are called extrapyramidal. So let me explain what I mean by that now. When we refer to the pyramidal system of the nervous system, we're talking about the cortical spinal tract, and it gets the name pyramidal system because the cortical spinal tract runs in the pyramids of the medulla. And if you damage this system, that will cause weakness. You won't be able to move your arms or your legs. The extrapyramidal system is the basal ganglia nuclei and associated tracts. This system is responsible for modulation of movement. And if you damage or inhibit this system, that will lead to movement disorders similar to Parkinson's syndrome. And this is what happens in patients who take first generation dopamine blocking drugs. They get movement disorders that resemble Parkinson's disease, and those are called extrapyramidal side effects. So, extrapyramidal symptoms or extrapyramidal side effects are related to dopamine receptor blockade in the central nervous system. They are movement side effects, and there are 4 types of extrapyramidal side effects you can see in patients on first generation drugs. They are called dystonia, akathisia, bradykinesia, and tardive dyskinesia, and we'll go through each of these 4 in the next few slides. Dystonia is an extrapyramidal symptom that you can see in patients taking first generation drugs. It occurs because of dopamine blockade, and it's an acute side effect. It can occur within hours or days of taking the drug. I've seen this in patients in the hospital just a few hours after a single dose of haloperidol. Dystonia means an involuntary contraction of muscles, so this symptom presents as spasms or stiffness. Patients will say they can't move their arm or their jaw is locked. This is a dystonic reaction to one of the antipsychotic drugs. The treatment for this is a drug called benztropine, and you can just think of benztropine as a drug that unfreezes muscles. That's basically what it does. It's an anticholinergic drug. It blocks M1 receptors, and this improves dystonia. And as we'll see, it's also used in some other extrapyramidal symptoms, but only in cases where patients are frozen, not in cases where patients are tremorous or shaking. It won't work in that situation because what it does is it unfreezes muscles. Our next extrapyramidal side effect is akathisia. This occurs within days of starting one of these antipsychotic medications. And among all the extrapyramidal side effects, this one is the most common. Many patients who take these drugs complain of akathisia. Akathisia is a sense of restlessness or an urge to move. Many patients will simply say they feel very jittery when they're taking one of these medications. In some cases, it's misdiagnosed as worsening psychotic agitation when, in fact, it's a side effect of the drugs. The treatment is to lower the dose of the antipsychotic medication if that's possible. Benzodiazepines can sometimes settle this symptom down, and the beta blocker propranolol is also used. Now, there are some limited data that say benztropine can be used in this situation, and you'll find that in some books, but you should be aware that benztropine is second line for akathisia as opposed to other extrapyramidal symptoms. And the reason for that is because, as we just talked about, benztropine unlocks muscles and helps muscles to move. And in general, that is often not helpful when patients are restless and already have an urge to move. But there are some limited data that it has some effect, so you will see that in textbooks. Bradykinesia is the third extrapyramidal side effect. This occurs within weeks after starting one of the dopamine blocking drugs. This side effect is sometimes referred to as drug-induced Parkinsonism, and that's because these patients have very slow movements, much like in Parkinson's disease. And in this situation, you can use benztropine just like for dystonia. That's because, once again, here you have frozen muscles, muscles that won't move. That's why the patient's movements are slow, and that's why benztropine can be used. The last extrapyramidal side effect is tardive dyskinesia. This is also the worst of the 4 extrapyramidal side effects. The word tardive means late, and it gets this name because this side effect occurs months or years after starting a dopamine blocking drug, as opposed to the other side effects we've been talking about up until now, which start earlier than that. The key feature of tardive dyskinesia is something called chorioathetosis. So let's talk about what this word means. So chorea is an irregular migrating contraction. So patients will move their arms sort of in a snake-like motion. Athetosis means a twisting and writhing. So patients will often have these twisting and writhing irregular motions, usually of their mouth, tongue, face, or limbs. I've seen this in a couple of patients over my career. They are often smacking their lips or grimacing in a way that they just can't stop. They do this sort of like a nervous tic, and this is often irreversible. Even if you stop the drug, it won't help. And this is one of the main reasons that the first generation antipsychotics are no longer used for long-term therapy, because when you had to do that years ago, when these were the only drugs available, a percentage of patients would develop this side effect and have a permanent motor dysfunction because of the drug. The first generation antipsychotics vary in their frequency of side effects, and I mentioned this earlier, how chlorpromazine blocks alpha-1 and serotonin receptors more than dopamine. Haloperidol, on the other hand, blocks dopamine the most, and these others less than dopamine receptors. One way the first generation antipsychotics are often broken down is into high potency and low potency agents. So the high potency agents are drugs like haloperidol, trifluoroperazine, and fluphenazine. These drugs are called high potency because they're very potent. It takes a lower dose to achieve the desired effect. For example, the typical dose of Haldol, which is another name for haloperidol, is only 1 milligram, a very small dose. And these high potency agents tend to have little effect on histamine and muscarinic receptors, so they have very little dry mouth. That's from muscarinic blockade, or sedation from histamine blockade. The main side effects of the high potency agents are extrapyramidal side effects, and that's because they're very strong dopamine blockers. Just like haloperidol shown in the bottom of the screen here, they tend to block dopamine receptors more than any other type of receptor. Low potency first generation antipsychotics are drugs like thioridazine and chlorpromazine, and they're called low potency because they're less potent. It takes a higher milligram dosage to achieve the effect. For example, thioridazine requires a dose of 50 to 100 milligrams compared to the 1 milligram dose of haloperidol we talked about on the last slide. And the thing to know about the low potency agents is that they tend to have less extrapyramidal side effects and more non-neurologic side effects. In other words, more of the non-movement related side effects. They tend to be sedating. These drugs are sometimes called sedatives, and they often cause dry mouth. And years ago, if you were a doctor in the 1950s, before benzodiazepines and other drugs were available, these drugs, these low potency agents, were commonly administered to patients with agitation because they were sedating and they would calm them down. So you can think of these first generation agents as a spectrum. The low potency agents, like those over here, have lots of non-extrapyramidal side effects like sedation and dry mouth. The high potency agents, like those on the other end of the spectrum, tend to have more EPS or movement symptoms related to the drugs. All the side effects of first generation antipsychotics that we've talked about up until this point have involved blockade of some receptor type like histamine or dopamine. But now I'm going to talk about other side effects of the first generation antipsychotics, and these are effects that aren't related directly to one specific receptor type. And the first of these side effects is neuroleptic malignant syndrome, or NMS. This is a rare, dangerous reaction to neuroleptics, in other words, to antipsychotic drugs. It usually starts about a week after a patient starts taking one of these drugs. The mechanism of this adverse effect is poorly understood, but the key features are fever and rigid muscles. This is what you want to watch out for in a board question. If you see rigid muscles, you may be thinking of some extrapyramidal side effect, but if there is fever involved, you should think of NMS. In addition, the patient usually develops mental status changes. This is a form of encephalopathy, and there's also muscle damage, so creatine kinase levels will rise in the blood. You can detect these on a blood test. There can be myoglobinuria, which can lead to acute renal failure and rhabdomyolysis. The treatment is with dantrolene, which is a muscle relaxant, or bromocriptine, which is a dopamine agonist. And in the musculoskeletal section, in the video on skeletal muscle, I talk about malignant hyperthermia. That is a very similar clinical syndrome to NMS. Malignant hyperthermia is related to the ryanodine receptor. That's not the case for NMS. But malignant hyperthermia develops among patients who receive the anesthetic halothane or succinylcholine. It looks a lot like NMS with fever and rigid muscles, and it has the same treatment, which is dantrolene, a muscle relaxant. Some of the antipsychotics may prolong the QT interval. That's because some of these drugs have cardiac potassium channel blocking effects. And in the video on antiarrhythmic drugs, in the cardiology section, I talk about how drugs that block cardiac potassium channels usually prolong the QT interval. And if the QT interval becomes prolonged enough, it can lead to torsade de Pointes, which is a life-threatening cardiac arrhythmia. And among all the antipsychotics, the one that's famous for doing this is IV haloperidol. Some of the antipsychotics can have ocular or eye side effects. These usually aren't seen in the modern era, but years ago, when patients took first generation antipsychotics for long periods of time, some of these ocular effects could develop. Chlorpromazine begins with a C, and that can help you remember that it may cause corneal deposits. Remember, the cornea is in the front of your eye, and that's where you'll see these deposits. And in some cases, this used to accelerate the aging of the lens in patients on this drug. Thioridazine has an R in the middle of the name, and that can help you remember that it leads to retinal deposits. Remember, the retina is in the back of the eye, so deposits can form there. In some cases, it would look like retinitis pigmentosa. This is a picture of retinitis pigmentosa shown on the screen here. This is a disorder caused when children have loss of rods and cones, but you can see similar features in patients who have thioridazine complications. What patients used to complain about when they got this side effect was browning of their vision. And years ago, when doctors prescribed thioridazine long term, they would use a low dose to avoid this side effect. Now we're going to move on and talk about the second generation or atypical antipsychotic drugs. And just like the first generation drugs, these drugs also have properties whereby they block dopamine receptors and histamine receptors and other receptors to varying degrees depending on the drug. The main difference between the second generation drugs and the first generation drugs is that the second generation drugs have far fewer side effects, and in particular, they have a much lower rate of extrapyramidal adverse effects. And that's why these drugs are much more commonly used for chronic therapy of conditions like schizophrenia in the modern era, because patients are much less likely to develop extrapyramidal side effects and other side effects. Most of the second generation drugs end either in apine or idone. The one exception is a drug called aripiprazole, which we'll talk about at the end of this video. One thing to know about the second generation antipsychotics is that many of them have significant serotonin receptor blocking effects. So years ago, people were studying LSD, which is lysergic acid diethylamide. It's a drug of abuse that I talk about in substance abuse videos. And people figured out that one of the reasons LSD makes you hallucinate is because it activates serotonin receptors. In particular, they found out that the 2A subtype of serotonin receptors was responsible for many of the hallucinations caused by LSD. Later, people studied the atypical or second generation antipsychotics and found that many of these drugs significantly block the 2A subtype of serotonin receptors. And in fact, many of these drugs are as or more effective serotonin blockers compared with dopamine. So for example, if you look at the bottom of this slide, two second generation drugs are shown here, clozapine and olanzapine. So clozapine blocks alpha-1 receptors more than serotonin, but it blocks serotonin more than dopamine, and this is typical of the second generation agents. Olanzapine blocks serotonin more than histamine and dopamine, and it blocks alpha-1 receptors the least. But this pattern of more serotonin block compared to dopamine block is seen among many of the second generation agents, and this is believed to be why they're better at reducing psychosis without causing as many side effects as the first generation drugs. So these drugs can be used in the treatment of schizophrenia. They are the mainstay of treatment for schizophrenia in the modern era. Classically, it was taught that the second generation drugs improve both the positive and the negative symptoms. There have been recent studies showing that these drugs probably have very little benefit on the negative symptoms. Negative symptoms are notoriously difficult to treat, but nevertheless, you will see in some sources that these drugs can be used to improve negative symptoms. Second generation drugs are also used to treat bipolar disorder, obsessive compulsive disorder, anxiety disorders, depression, and even Tourette syndrome. And we'll talk about the special side effects of these drugs in a minute, but just a key point to remember in general is that the reason these drugs are so popular in the modern era compared to the first generation drugs is that they have fewer extrapyramidal side effects and fewer anticholinergic effects. And then also, just like with the first generation drugs, these drugs can prolong the QT interval. So what are some of the special side effects of the second generation agents? The first one is metabolic syndrome. Now, this can occur with any antipsychotic. However, it is most common with two second generation agents, clozapine and olanzapine. And the metabolic syndrome refers to weight gain, hyperglycemia, and hyperlipidemia. This triad happens to a lot of people with schizophrenia who have to take these drugs. And it's very unfortunate. They become very overweight and they can develop high cholesterol and diabetes. And it's all related to the therapy they have to take for their schizophrenia. Clozapine has some special side effects you should be aware of. It's potentially toxic to the bone marrow. In 1 to 2% of patients, it causes agranulocytosis, which makes patients prone to dangerous infections. For that reason, any patient that takes this drug has to get a white blood cell count every week at the start and then every few weeks to every month thereafter to make sure they don't develop this side effect. It's reversible when the drug is stopped, so if you pick it up before the patient's white blood cells plummet and before they get an infection, then you can stop them from getting sick. In addition, up to 5% of patients in some studies have seizures on this drug. It's dose related, but this is another potential side effect. So it's high yield for your board exams to know about agranulocytosis and seizures for patients on clozapine. Next, let's talk about hyperprolactinemia, which I discuss in detail in the endocrine section in the video on the pituitary gland. Antipsychotic drugs are the most common drug-induced cause of hyperprolactinemia. It's high yield to remember that. And that's because all these drugs have some dopamine blocking effect, and dopamine suppresses prolactin release from the pituitary gland. So when you block dopamine, you get increased prolactin release. This will present as amenorrhea in women, it can present as gynecomastia in men, and it can also present with galactorrhea. So basically, anytime you see these three things, you measure a prolactin level. And if it's elevated, the first thing you want to do is scan the head to make sure the patient doesn't have a pituitary adenoma. Once you scan the head and you find it's normal, the next thing you want to do is look at their med list because there are lots and lots of causes of medication-induced hyperprolactinemia. And among all those causes, antipsychotics are the most common. The highest rates are seen with these four drugs I've shown here. Now, patients in the modern era usually are not prescribed first-generation agents like haloperidol or fluphenazine for long periods of time. So you rarely see a patient walk in who chronically takes one of these drugs and has high prolactin levels. But the second-generation agents are prescribed for long periods of time, and two of those drugs, risperidone and paliperidone, are commonly associated with high prolactin levels and hyperprolactinemia. I'll finish with this slide on aripiprazole, which has an unusual mechanism of action among the second-generation antipsychotics. Aripiprazole is a partial agonist of D2 receptors, so it has some blocking and some agonist effects. And the idea here is that with less dopamine blockade and some agonist effects, you may see less dopamine-related adverse effects. That's the goal of this drug. The most common side effect of this drug is akathisia, and that's easy to remember because I told you earlier that akathisia or restlessness is the most common of all the four extrapyramidal side effects. It's also the most common side effect of patients on this drug. And that concludes our video on antipsychotics.